Welcome. This is Alan Spitzer, Senior Vice President and Director of Research and Education for Pediatrics Medical Group. It is a pleasure to welcome you to this edition of our Pediatrics Grand Rounds podcast. We hope that you enjoy this new format. For more information on the current topic, please go to our website, www.pediatricsu.com, where you'll be able to view the slides discussed in the presentation and download a copy of today's talk. Now, on to Pediatrics University Grand Round.
Dr. Spitzer will talk about genomics, proteomics, metabolomics, so it's the mix talk. Quite a mix of things there, Alan. I'm not sure that you really need an introduction to this group, but you are currently Senior Vice President and Director of the Center for Research and Education and Quality at Pediatrics, and as such, Alan has already made a tremendous contribution to what Pediatrics has been able to do, and he has certainly made a huge contribution to getting the NEO conference to where it is currently. So, Alan?
Thanks very much, David. I feel like the pressure is on me at this moment to a very significant degree. The reason for that is 2 years ago, as happened to me yesterday, Dr. Ola Sogstad was supposed to arrive here and give a lecture, and unfortunately, because of weather, got trapped in Europe and was not able to make it here. And so 10 o'clock at night, the night before he was due to speak, he sent me an email saying that he couldn't speak, and I was panicky, and I said, well, let me look at his slides and I'll see if I can do something with this. And so I went ahead and gave his talk the next day. My own talk at that meeting occurred the following day. At the end of the meeting, several people came up to me and said, you know, we think you gave Dr. Sogstad's talk much better than you did your own. So I'm going to try to do better this time and talk about something that has become a major focus of my career over the past several years, and that's this whole concept of future medicine and where genomics, proteomics, and metabolomics are likely to take us. And for a moment, I would like you just to stop and think about how medicine is typically practiced today. You have an ache or a pain someplace, you go to the doctor and you say, "Doc, my shoulder hurts me." And he or she sits there and thinks, well, it may be arthritis, it may be a brewing heart attack, I better send some blood studies. And these studies are sent, some x-rays may be obtained, and then a diagnosis is made and a plan of treatment is selected. That's current medicine, and that's the way, in general, we approach a lot of problems, whether it's in a private practice or in the neonatal intensive care unit. What I think is likely to happen in the future is something that looks very different. And what will happen then is you will go to the doctor and say, "I feel fine." And the doctor will say, "Well, we're not sure about that. Let's send these genomic, proteomic tests, and we'll know when you are likely to develop that pain in your shoulder." And I think that that is obviously an exaggeration, but something that is likely to happen. I think we will be practicing medicine sometime in the next 5 to 10 years in a very different way, and hopefully over the course of this talk, I'll be able to generate that theme for you. My disclosures are that I'm an employee of Pediatrics Medical Group, and by virtue of my employment, own stock in the company. We no longer perform neonatal screening, and so there is no conflict of interest that we have at the present time. The objectives of this talk are to describe the use and background of tandem mass spectroscopy, and I'm sure just hearing that you're ready to leave the room, but hang in there. Discuss what studies have been completed in the areas of perinatal, fetal, and neonatal periods using these techniques, and discuss the reasons why these approaches offer great hope in the management of the high-risk pregnancy and critically ill neonate. Well, proteomics and metabolomics are really not an entirely new concept in medical care. They've really been with us for many years in the form of screening for neonatal metabolic disease. And I'm sure all of you, physicians and nurses, have drawn blood on a baby and put it on a typical filter paper, filling those little spots so that the blood hopefully doesn't extend out beyond the circle, sending it off to a laboratory someplace, and in general, never seeing the results. They disappear into the ozone until somebody gets called, you know, a couple weeks later saying, "Oh, this baby has a problem, where we need follow-up on this infant." I think that that will change, and the technology of screening, I think, is now going to be applied in a novel way so that we're not doing it to examine these sort of static diseases, but we're trying to look at diseases in an active and ongoing fashion. Just to give you the starting point for a lot of this, it was phenylketonuria, and as you very well know, phenylketonuria occurs when you have the failure of conversion of phenylalanine to tyrosine because of the absence of phenylalanine hydroxylase. There then is a backup of phenylalanine. There is decarboxylation, deamination into a variety of phenylketones that are toxic substances for the baby. If this is not diagnosed and detected, then this is an infant who is highly likely to develop severe brain injury, brain damage at some point in time, and to ultimately suffer the consequences of phenylketonuria. As you know, this is an eminently treatable disease because if it's detected very early on and dietary changes are made, many of these children can grow up normally, and there are many, many cases now of these children going on to have children of their own very successfully. So the quest that we have in keeping this in mind is many critical problems that occur during the neonatal-perinatal period can be assessed only indirectly or not at all. For example, does a mother have chorioamnionitis? A number of years ago, when I was at State University of New York at Stony Brook, our perinatologists did a study trying to see how good they were at diagnosing chorioamnionitis, and you could have flipped a coin because they were 53% accurate in making this diagnosis on a clinical basis. Will there be a preterm delivery? Obviously, this is one of the holy grails of obstetrics practice. It would be very nice to know early on which mother is likely to go on to develop a preterm delivery and to take steps at a stage before she starts having contractions in the hope that something can be done to prevent her from delivering preterm. Clearly, for the practicing neonatologist, is an infant septicemic. There is probably no more challenging diagnosis to us at the present time. If we draw a blood culture and we get back a negative culture, we very often say, well, he didn't look good on the first day, I'm going to treat him anyway. If we get back a positive culture, we go very often, oh, I think that's a contaminant, I'm not going to treat him. So even our gold standard of blood cultures is not very good at picking up the baby who is septicemic. Are there any perinatal inflammatory processes that might alter the baby's outcome? Can we predict which baby is in the process of developing periventricular leukomalacia, intraventricular hemorrhage, and a variety of other problems that occur commonly in the newborn period? So ideally, we'd like a technique that could identify potential problems before they clinically emerge. I'd like to know about which baby is going to develop bronchopulmonary dysplasia before the baby starts developing BPD. And is there a clinical crystal ball that might be able to reveal the potential for disease before that disease is manifest? There are a number of areas where one might expect great potential use for this type of diagnostic capability. Certainly in perinatal medicine, the ability to diagnose hypertension, preeclampsia before birth, subclinical infection in the mother, chorioamnionitis, the likelihood of preterm labor, successive rescue cerclage in preventing further development of labor, and certainly chromosomal abnormalities. At the present time, as you well know, our ability to detect even Down syndrome, third trimester, is only about, with quadruple screening, 88 to 92%. On the neonatal side, again, the presence of infection. Are we providing optimal nutrition for babies? We give babies a variety of things, but we don't look at the consequences other than the growth of the infant. So are we providing optimal perinatal nutrition for that particular infant? Is our TPN administration ideally suited for the baby? Are there markers of perinatal hypoxic ischemic injury that might be of value in diagnosing when an injury may have occurred? Are there other cytokines or inflammatory mediators that we might take a look at that would be very interesting and revealing to us in terms of trying to diagnose what's happening to an infant? If these are elevated at an early time and we only have to screen the baby with a single drop of blood, can we do that frequently to follow the trending changes that might occur in some fashion? What are the effects of steroids? Are they good or bad in certain infants? Some babies may actually benefit from steroid use when given at selected periods of time. Other babies, as we well know, who are placed on postnatal steroids may have serious adverse consequences from that. To go back to the perinatal period, preterm birth is obviously one of the most costly and underserved issues. As you can see here, that if you look at the 2 or 3 most expensive conditions that are treated in hospitals, pregnancy and delivery, even regular pregnancy and delivery, accounts for $44 billion a year in healthcare costs, and newborn infants are about $35 billion. Preterm birth is very costly. The estimated cost of this annually is about $26 billion in the United States. Term infants cost about $1,700 on the average to house in a regular nursery. The average cost of a preterm infant is about $77,000. The rate of preterm infants has been rising. I saw the most recent statistics. I think they were from 2008. It looks like there's a little bit of a dip down for the first time in quite a few years, but we're still up close to 13% of deliveries being preterm. Internationally, there are about 14 million preterm births. There are about 1 million neonatal deaths a year. 27% of these deaths are due to prematurity. And I don't think I have to read the rest for you here. All of us know that premature birth is a major problem throughout the world. 90% of these deaths, both maternal and neonatal, occur in the developing world. If you look at the critical conditions that are often associated with pregnancy where these types of anticipatory testing might be of great value, clearly the case of the baby who might, or the mother who might deliver preterm, patients at risk for preeclampsia, Down syndrome testing. Obviously, many pregnancies are affected each year. We have about 545,000 preterm births in the United States annually. And we have about 1 to 1.5 million evaluations for neonatal sepsis, which is the most frequent admitting diagnosis to the neonatal intensive care unit. About 30% of all NICU admissions are for evaluation of neonatal sepsis. Well, how do we begin to look at this? There are a lot of very unique things that occur during pregnancy, labor, delivery, and subsequent neonatal course, and there are about 1 million proteins to take a look at. One of the most interesting approaches was developed by Serena Gala, working at the Argonne Health Science Center, who began to characterize the unique proteins of pregnancy, or the proteome of pregnancy. And by looking at a variety of substances, neonatal blood, umbilical cord, cervical vaginal fluid, amniotic fluid, maternal serum, he began to look at the changes that are occurring during pregnancy, subsequent delivery, that might be important in diagnosing some of these critical conditions that I just mentioned. So the development of a non-invasive test for intraamniotic fluid infection is certainly high on the priority list of something that might be of great value. Well, how do you begin to consider these types of changes? Well, all of metabolism, both normal and abnormal, works through protein activity. Proteins are really one of the major keys. Before a disease can manifest clinically, there has to be some type of abnormal concentration of some protein or proteins or metabolites in the blood or regional in the body. If your proteins have not changed, you're not going to have any disease. You're in a state of homeostasis. So that something must happen to the proteins or their metabolites before diseases begin to demonstrate themselves. So that theoretically, it should be possible to identify amino acid, protein, or other metabolic biomarkers in the blood and relate the presence of these biomarkers to the future injury and disease states, ideally before they actually occur. In the case of intraamniotic infection, about 80 to 90% of these infections have no clinical signs of symptoms in the mother. Only a small percentage of women will actually be hyperthermic, develop a fever. For women in preterm labor, there's about a 12 to 34% risk of intraamniotic infection, leading to at least 20%. I think in this slide is probably an underestimate of all preterm births, and about 50% of very low birth weight neonates. With those patients, there's an increased risk of neonatal sepsis, respiratory distress syndrome, and most significantly, cerebral palsy. Cerebral palsy can lead potentially to an added cost in the care that's estimated at a minimum of about $500,000, but potentially more over one of those child's lifetimes. The current gold standard is amniocentesis with lab culture for making this diagnosis. Intraamniotic infection, as I mentioned, is responsible for about 10 to 20% of all preterm births and more than 50% of low birth weight neonates born before 30 weeks of gestation. It does produce a robust inflammatory response, and compared to gestational age-matched controls, low birth weight neonates born in the setting of intraamniotic infection show increased risk of sepsis, respiratory distress syndrome, grade 3 or 4 IVH, PVL, and neonatal seizures, all of which are significant here, as you can see. So that the hypothesis here is that among women in preterm labor, systemic analysis of vaginal fluid or maternal blood proteome could identify sensitive novel biomarkers for intraamniotic infection and preterm birth. Such biomarkers theoretically could lead to the development of less invasive tests to predict intraamniotic infection and preterm birth among women in preterm labor. Potentially, this could have a very significant impact on clinical treatment if we could anticipate these conditions at a point in time when they are much more remediable than they are at present. Well, what are the current candidates for looking at a lot of these things? We mentioned proteins and metabolites. Is there anything else? We've heard a great deal in recent years about the genome. Working out of the genome was supposed to take care of everything. This was supposed to tell us who is at risk for what type of illness or not. And theoretically, the genome, the blueprint for every individual, should be able to identify the underlying potential for a variety of disease states. It does not, however, predict the timing of events because gene expression is very variable. People very often throughout their life carry a certain gene, but it never expresses itself, so that disease does not occur. The genome does not reflect changes in any acute phases of diseases, although one can measure some up and down regulation, typically of messenger RNA, that may be valuable, but for the most part, the genome reflects quantitative relationships poorly in most of these acute cases. So the problem then with the genome is that it contains a wealth of information that helps an organism to survive, but this blueprint does not reveal which of the encoded molecules are relevant under any given condition. Except perhaps if one could actually recover, in the case of neonatal sepsis, the actual bacterial genome. Is that possible? Well, it is. And in fact, one of the interesting approaches that's now being looked at that our perinatologists are currently engaged in is the detection of the bacterial ribosome in the circulation and in the vaginal fluid of pregnant women. In particular, 16, 18, and 23S ribosomes from the bacteria are detectable in maternal circulation and vaginal secretions. You can see that by PCR this is possible, and one can then take this to the higher level of looking at the genome of the bacteria to make a diagnosis. What other candidates exist? Well, we certainly have the proteome, as I mentioned, metabolome. The proteome, as I mentioned, is the builder and the more likely candidate to predict active disease states as new proteins are expressed through up and down regulation. The metabolome, in some cases, is easier to look at because you have the finished product or byproduct of a metabolic process. And some diseases may be better reflected by measuring the byproducts of altered metabolism. So here is what I think is the ultimate potential of looking at all of these diseases, particularly in neonatal-perinatal medicine, in this new fashion. The genome will identify the genetic potential, genetic material, or allow assessment of up and down regulation of messenger RNA. We may be able to get the actual bacterial genome in the cases of infection. The proteome, or the collection of proteins within a biological system, will be very valuable, and proteomics refers to the systematic study of proteins and their function. And lastly, the metabolome is the collection of metabolic products within a biological system, which also may be very helpful in seeing what the effects of the protein are on metabolism. What we have here in the process then is we have our genome as shown by DNA. There is then a transcription to RNA, and this is often referred to as a transcriptome. A series of proteins are made that then undergo a variety of modifications, ultimately exerting their influence, producing metabolites, having some biological function or pathophysiological function, and then this then feeds back to determine how much of this process continues on. We start off with about 40,000 genes, we make about 100,000 different proteins, and then as these undergo the modification, there are well over 1 million proteins that we ultimately have to deal with in the body. But this is the basic process that we're talking about. If we could better understand the genomics and proteomics of the circumstance, we are likely to have, number one, a better understanding of the pathophysiology of diseases. This will allow us to develop new biomarkers for these diseases at a variety of points in the disease progression. And lastly, and perhaps most importantly, it may allow us to use designer drugs. Now, these are not the designer drugs that you take out on the street corner someplace, but these are the designer drugs that are much more specifically tailored for somebody's disease process. If you think about what we typically do now, especially in adult medicine, where you may treat a 100-pound woman and a 300-pound man with the same dose of a drug, that is probably suboptimal therapy. We try our best in the neonatal period to adjust drug doses based on kilograms of body weight, but we often don't take into account the amount of body water, the amount of fat that is present into which many drugs basically deposit themselves, and we have a poor ability to calculate what is actually happening in drug metabolism. And I think with the use of these techniques, ultimately down the road, we will be able to design drugs and use drugs much more efficiently and thoughtfully than we currently do. Well, how can we examine, if there's 1 million or more proteins and circulating, how can we examine all of these at one time? Typically, as I mentioned earlier, we have the lab reagent approach where we send off a vial of blood and they do a few tests on that and you get back the results. What we require is really a technique that can examine large numbers of proteins or metabolites at the same time, and this is mass spectroscopy. And we deal with rapid change with mass spectroscopy by utilizing tiny volume specimens. This allows the performance of frequent studies. You can then, by frequently looking at these things, take a look at trending changes that might occur in the evolution of the disease process or whatever it is you're particularly interested in looking at. And mass spec is an ideal way to achieve this goal of looking at all of these substances on very small volumes of blood. Now, for those of you who don't know what I'm talking about with tandem mass spec and mass spectroscopy, I'm going to try to run through this very quickly, and hopefully, thanks to Don Chase's wonderful slides that I've borrowed from him, you will understand this a little bit better because you're probably metabolically challenged the way I am. As I mentioned, mass spec was first used in clinical application with newborn screening. They took PKU. This has been expanded by the states now, and typically many of our states test for over 50 metabolites at the present time. Ultimately, mass spec develops what's referred to as a mass spectrum, and this is the result that you get back from the filter paper spot that you send that allows you to identify the amino acids, proteins, and metabolites, as well as other agents that appear in the spectrum. And ultimately, by combining this mass spectrum with the results of the genomics of the mother, the neonate, or the invading microorganism, I think we will have a much better handle on defining the present susceptibility and active nature of a variety of disease states. Going back to your high school chemistry, if you remember what mass is, this is the weight of a molecule. Water, for example, has 2 hydrogens and 1 oxygen. Hydrogen ions have an atomic weight of 1, oxygen 16, so the mass of water, is 18. Mass spectrometers detect the mass of a molecule and measure how many molecules of the specific mass might be present, so you can get a sense of how abnormal is the clinical situation. These results are, as I showed you, displayed in a chart called the mass spectrum. When we talk about tandem mass spectrometry, we talk about two mass specs that measure mass before and after fragmentation. Fragments are like pieces of molecules that have functions like syllables and words, and I'm sure at this point in time you have no idea what I'm talking about. So let me try to illustrate it a little bit more clearly. If I ask you to take out your change and sort it, you can do that quite frequently and put it into dimes, cents, nickels, quarters, half dollars, etc. Essentially what a mass spectrometer does is the same thing, but it takes the quantity of ions and looks at the various number of ions of a certain mass that are present after this collision occurs. Well, how does this occur? We have all of these molecules that are present in the body that have various atomic weights, but the problem is that there are often more than one molecule in the body that has the same atomic weight and the same mass. So that ideally we have to figure out which of the specific molecules we want to look at. So what we do is induce a collision with the second mass spectrometer, and that collision fragments the molecule into these syllables or smaller products that can then be sorted out. And ultimately, one of these can then look at the result as it hits the mass spectrometer detector. And over the course of time, ultimately, the mass spectrum is developed. So that's basically all a mass spectrometer does, is it's a way of looking at how many molecules of a certain mass are present in the sample that we put through the mass spectrometer. Clinically, we take a filter paper spot of blood, as I mentioned. It's bombarded in the mass spec chamber. This provides a mass of molecules, proteins, whatever we're looking at, that are present, and tells us how many of those are present, and provides measures of relative amounts of the molecules or biomarkers that could give us an indication of how severe a clinical situation might be. As I mentioned, this is something that's occurring more and more. This is not speculative science fiction. This is a reality that's beginning to happen, and what you can see here is that you have the patient, a proteomic pattern is sent on that patient, an early diagnosis is made. This may lead to some type of procedure. One then goes through the entire process again to have a repeat study done on a mass spectrum that might give you indication as to how effective your therapy might be. There are a number of areas where medicine in general is moving into this proteomic future. Oncology is obviously a very important target for being able to detect disease before it becomes clinically apparent. And as tumors of a variety of types develop in the body, theoretically these tumors should have unique proteins that could be detected by tandem mass spec. Monitoring for cardiac ischemia and toxicity, it would be very nice to know which patient is likely to have problems, which individual is developing an ischemic myocardium that ultimately would be amenable to treatment at an early stage as opposed to after a myocardial infarction. Diabetes care, infectious diseases, as I mentioned, a variety of immunology issues, toxicity monitoring of drugs are all very, very amenable to this type of approach. Here's an article from the Journal of the AMA last year looking at CSF biomarkers and incipient Alzheimer's disease. And you can imagine that there's a lot of work underway right now in Alzheimer's disease, Parkinson's disease, a variety of other neurologic conditions. We're beginning to get interested in the process of looking at neurologic injury in babies and biomarkers for that. And you can see how with Alzheimer's disease, the proteomics here divides up in a number of ways so that you can separate your controls from incipient Alzheimer's disease quite easily, and this is likely to be an important diagnostic tool that hopefully can begin to address Alzheimer's disease before there is significant loss of memory and other functions that we associate with Alzheimer's. In neonatal-perinatal proteomics, there's a great deal of work going on with amniotic fluid, and I'll show you more of this in a few moments. I mentioned, obviously, that to date there's been sort of a shotgun approach, and what Dr. Nagala has done in trying to limit the amount of proteins that are being looked at is a very valuable, important adjunct to this therapy, because it's impossible to look at the million of proteins. It's like looking for a needle in a haystack unless you begin to narrow things down the way that he has done and refine your approach. What was one of the most important, and I think first, papers in this regard in the prenatal period looked at intraamniotic infection. This was done using amniocentesis. We're now moving to looking, as I mentioned, at vaginal fluid and the maternal circulation in a much easier, non-invasive way to identify novel biomarkers. And Dr. Gravin, and working with Dr. Nagala, showed a number of years ago that there are a series of peaks. These are polypeptides diagnosed by Tandem mass spec that are overexpressed during perinatal infection. They did this both in primates and in humans. You can see that there are primates up on top, humans, and the responsiveness to these same proteins in the face of infection were quite similar. So that this may help us anticipate which mother is likely to go on or has an infection that should be treated at an earlier rather than a later stage. Most recently are maternal fetal physicians working with Proteomics, which is Dr. Nagala's company out at the Oregon Health Science Center, presented a very interesting abstract at the Society for Maternal Fetal Medicine this year, where they looked at a series of mothers who had culture-positive infection, not infected but had preterm birth, and not infected and went on to have term labors. And what they found was that when they cultured these women, only 12 were positive, 6 had urealyticum. But what they found was when they did the PCR for this and began to look at identifying the genomics of the bacteria, they were able to detect the bacterial ribosome in 16 women, 4 women more than were able to be detected with culture alone. All 12 cases were culture positive and also positive for 16S ribosomal DNA. 4 cases with negative cultures had positive 16S ribosomal DNA cultures, and these identified species that were not recovered by culture that are listed here. So that what they concluded was that this is a novel way of using certain biomarkers, in this case the bacterial ribosome, to detect at an early phase. One of the nice additional features of this is that the negative predictive value, which mothers were not infected, was extremely high at 98.3%. The sensitivity and specificity were pretty good at close to 90% in this particular trial. So this is an early look at some work that I think will have a very important bearing down the road on the detection of intraamniotic infection. In preterm labor, Dr. Romero a number of years ago published at the SMFM, and I haven't seen the final paper of this. They did something very similar, looking at preterm labor, a series of mothers with premature contractions who delivered at term, mothers with preterm labor and choreo identified by Tandem mass spec, and mothers with preterm labor and no infection, and these were all appropriately classified in this particular trial. Dr. Nagala again began to look at this with Dr. Romero, and they found that there were 28 proteins that were present in differential concentrations in mothers with preterm labor compared to normal pregnancies. And so I think that this is an emerging area that is very likely to have enormous anticipatory value in predicting which mother will be in preterm labor at some point in the future. Another form of mass spectroscopy, MALDI-TOF, was very valuable in diagnosing down biomarkers. This seems to be 100% sensitive and 100% specific. There's more work going on in this area right now, but it appears that there are certain abnormal proteins that appear that are very unique to Down syndrome. Not surprising, and I think we'll be seeing more of this particular technique in chromosomal abnormalities and other genetic detection in the very near future. One of the areas that I mentioned briefly yesterday that we've been looking at for a while has been nutritional adequacy as detected by tandem mass spectroscopy. And this is a study that we performed and reported now about 3 years ago. that we're now following up with what I think is probably likely to be the largest nutritional study ever done in the preterm infant. We're in the prospect of enrolling 1,000 babies, looking at the effects of illness on their metabolism during the neonatal period. These are babies under 1,250 grams, to look at the effects of sepsis and a variety of other things on nutritional adequacy. But for this initial study, there were a couple things brought to my attention originally by Don Chase, who is our PhD that we work closely with, who is really an incredible observer of a variety of events. And what Don pointed out was that he could always tell by looking at tandem mass spec of preemies which baby was on TPN. And I said, well, how do you do that? And he showed me this particular graph. Up on the top, what you see, this normal number 1 is a baby. Here's phenylalanine, here's tyrosine, and you can see that the ratios of phenylalanine to tyrosine are quite comparable. This is normal metabolism of phenylalanine to tyrosine, so those amino acids are pretty much being appropriately metabolized. Down at the bottom, we have a baby with phenylketonuria. And here you can see that the phenylalanine is much higher than the tyrosine levels, indicating that there is a significant block in metabolism and accumulation of phenylalanine. But this baby in the middle is pretty interesting. This is a normal preterm infant, but this is a baby who is on parenteral nutrition. And you can see that this particular baby seems to have at least a partial conversion problem and is not quite able to appropriately metabolize phenylalanine to tyrosine. What happens to a baby where this is allowed to continue on for weeks, as many of our infants are unable to feed and may require parenteral nutrition for that protracted period of time? Is this a situation that could adversely affect neurodevelopmental outcome? It's a question that I think has to be asked at the present time. So we followed this up with a prospective randomized trial that was published in Pediatrics back in 2007, and we had 11 of our centers participating in this. And what we did essentially was give 2 different amino acid mixes to the babies. One received 3.5 grams per kilo per day of protein as the maximum total. The other received 2.5 and looked like this over the course of the first month of life. Here is the total amino acid mix. These are not means plus and minus standard deviations. For the next several slides, you'll see medians and 75th and 25th percentiles, so they'll look a little bit different than you're typically used to looking at the error bars with means and standard deviations or standard errors. But you can see that the 3.5 gram group got significantly more, about 1/3 more protein, both at 7 days and at 28 days than the 2.5 gram group. Our endpoint was growth. Could you make the babies grow faster during that first month of life if you gave them more protein? And the bottom line was that there was no statistical difference between these two. And in fact, if I actually showed you the means and standard deviations, they're virtually identical. But we just presented it as the medians. And these babies did not have any significant difference in weight gain during that time. Length and head circumference were also identical. But we began looking at some of the amino acids, and while in this particular trial the phenylketone problem was not as much of an issue, there were other areas where there did seem to be some issues. And we looked at leucine isoleucine, which is the primary component or the most common amino acid found in our typical parenteral nutrition solutions, such as trophamine. Over here, what you see is the 10th and the 90th percentile, and this is term baby data that we had from the time that we ran our newborn screening labs. There is no comparison data for preterm babies, and one of the outcomes of the trial that we're currently engaged in is we hope to generate premature baby data so that when we send off these screening results to the lab, we can begin to make sense out of them. And what you saw was that on the first day of life, the values of leucine and isoleucine were pretty comparable to the median, or 50th percentile, for the term baby. By day 7, they were up around the 90-plus percentile for the median on the 3.5 gram group, a little bit lower on the 2.5 gram group, back down to a more normal range by 28 days. But we also began to think about something else, and that's the fact that in disease states such as isovaleric acidemia, what happens is in the process of converting leucine, if there is a block in isovalyryl-CoA dehydrogenase, ultimately there is the formation of acylcarnitines, such as isovaleric-carnitine, which occur in the circulation in excessive concentrations. And so we looked at our TPN solutions here, again using mass spec, and found that if you look at the isovaleric-carnitine concentrations of these babies on TPN, what you find is that, again, here's the 10th to the 90th percentile. By day 7 in the 3.5 gram group, you can see that the median for the 3.5 gram group is way higher than is true in the term baby metabolizing, we hope, normally. Your 75th percentile is way up here, probably twice as high. And in the 90th plus percentile, there's about a 3.5 time increase above normal. Not quite what you would see in a situation of isovaleric acidemia, but without any question, many, many times higher than one would like to see in a preterm baby with a developing brain. And so what the influence of these abnormal concentrations of metabolites in this case might be on neurodevelopment is something that has to be raised as a question, something that we do not have an answer for at the present time, but we hope that with our additional studies we'll be able to look at this in a variety of circumstances. What I'm particularly concerned about is that if you have these elevated concentrations in relatively well-growing preterm babies simply on parenteral nutrition, what happens to this baby in the face of septicemia? If you block the liver metabolism so that things are even worse than they normally are, do the concentrations of such things as isovaleric-carnitine go up to levels that are very, very toxic to the neonate's brain? I think these are issues for us that we need to explore. Some of the other amino acids that we saw in this particular trial were too low. Alanine was, for the most part, at the 10th percentile or below for a significant number of babies. And then there were other metabolites like tyrosine that bounced around quite a bit, or I should say amino acids that bounced around quite a bit, that were interesting, as I'll show you in a second, because of their parallels to thyroid hormone metabolism. So our conclusion from this trial using mass spectroscopy was that a more aggressive approach to parenteral amino acid support does not really improve growth and was associated with higher levels of some amino acids and BUN. Despite parenteral amino acid supplementation, some amino acid levels were low compared to normal values for term neonates, and in very immature neonates, the quantity and the quality of amino acid supplementation may need to be much better individualized and tailored to the specific needs of the infant. We sort of do the same thing that I mentioned earlier with the 100-pound woman, the 300-pound guy, and give the same kind of doses, but this may not be ideal for each baby. Monitoring of electrolytes, glucose, and triglyceride levels do not allow us to evaluate amino acid balance or amino acid tolerance in the extremely low birth weight baby. And we really can't be certain that these subtle increases in amino acids in the higher dose group are safe for the developing brain of a premature neonate for the reasons that I tried to point out. Similarly, deficits in certain essential amino acids may actually hinder normal development. So we just are not providing babies with this optimal mix. Saturation may occur in some concerning pathways that are known to be associated with neurotoxicity. It may occur in leucine-isoleucine metabolism. It may occur in phenylalanine metabolism. There appear to be, in some cases, high levels of amino acids in these babies and failure of conversions of some amino acids, suggesting that we really need at some point to begin considering the monitoring of amino acid levels after we administer these to babies. And if you had the capability of doing mass spec and getting quick turnaround time, this is something that we think people would do on a regular basis. Most importantly, this did not really increase growth at 1 month of life. And it's suggested to us that our current parenteral nutrition solutions are really not optimally formulated for the preterm infant. And as I mentioned, we have a current large study in progress to try to look at this further. Some of the secondary outcomes for this trial were interesting also. We looked at cholestatic jaundice, a common problem that people worry about with parenteral nutrition. Jaundiced infants in this particular trial made up about 10% of the population. They were less mature and had lower birth weights. No surprise there. They were less likely to be on enteral feeding by day 7 of life. Again, that's not a surprise. One of the things that was a little interesting was that they were more likely to have a PDA and have received postnatal glucocorticoids, probably a reflection of the fact that these were somewhat more critically ill infants in general and were more likely to have an intraventricular hemorrhage. What you can see here in the first panel is that, as you might expect, the babies who developed cholestasis were receiving higher doses of total amino acids in the first 28 days of life. These infants were also more likely to have many more days on parenteral nutrition. What was particularly interesting is that BUN was higher, but there were biomarkers that we saw in this particular trial of amino acids on day 7 of life that seemed to be different from the babies that did not develop cholestasis, again suggesting that one could use these certain amino acid biomarkers to detect which baby is likely to go on to develop cholestatic jaundice long before they demonstrate cholestatic jaundice. And this is another area that we are attempting to look at in our current trial. So our goals of tandem mass spec Premie analysis are to really try to define better methods of caring for premature infants that combine the clinical care and the lab. Our concept ultimately is to have sort of a Premie screening panel. Because of the very limited amount of blood that's necessary, you could repeat these tests very frequently and get a great deal of information. And if I could give you information on the nutritional adequacy, risk of cholestatic jaundice, thyroid hormone levels, G6PD screening, steroid levels, cytokine levels, on, this would be potentially an extremely valuable test to do on a regular basis in the NICU. We are currently also embarking, besides the amino acid trial that we're doing, on a prospective trial of neonatal sepsis, looking for biomarkers of neonatal sepsis as well as the bacterial ribosomal findings in the circulation of the neonate with suspected septicemia. Our feeling is that this will help refine the diagnosis of neonatal sepsis quite a bit. We are also considering looking at markers of and recovery from neurologic injury using tandem mass spec analysis as well. Genomics, I think, adds a great deal to this prospect in terms of our ability now to look at the genome of bacteria. It seems to be of great value in understanding the disease potential in an individual, but also the bacterial infection genomics seem to be very valuable in allowing us to detect, is there a bacteria present, is there a fungus present, such as occurs with 18S and 23S ribosomal fractions. This can be detected with PCR amplification, and I think this is, again, very likely to be part of the future of diagnosis where we are anticipating disease and not simply reacting to the presence of a disease. Ultimately, we may be sending regular Premie metabolic checkups to the lab that you can get back all of this information on a regular basis to try to assess all of these valuable findings in the baby. And I think in the future, proteomic, metabolomic, and genomic assessment really represent novel, important future approaches to diagnosis and therapy. They will help us define the processes, both prenatal and postnatal, that are critical to understanding and producing optimal neonatal-perinatal outcomes. And I believe really that the approach to neonatal and perinatal medicine will change dramatically in future decades as we get a better handle on this. Thank you very much. I'll be happy to take any questions if people have them at this time. Frank.
Well, Alan and I are old friends, but I'm simply overwhelmed. But I was simply overwhelmed before I heard you talk about the whole process. I mean, look at the Human Genome Project, all the money we put into that. Okay, now I know there are 500 different mutations that cause cystic fibrosis. I know that every family that has Marfan syndrome has a different mutation, which just enormously complements the expense and the work of any patient with this disease, but doesn't necessarily change outcome. You talk about proteomics, 1 million proteins, yes, but those 1 million proteins have even millions more of single nucleotide polymorphisms or other polymorphisms. It's just totally overwhelming. And you talk about the metabiome. Well, the metabiome is going to make the human genome look like a tea party. Because, you know, if you do a cross-section of all the metabolic metabolites in a cc of human serum, it's just the noise there, my God, what are we looking for? What are we going to do with it? It's overwhelming. And I think two of the examples you gave sort of point this out to me, this mass tandem spectroscopy for newborn screening. We now screen for, I think, 59 different ones in Wisconsin. It doesn't matter that most of us never heard about what these are, never knew it was a problem before we started doing this. No one really knows if it's a problem. They don't know how to treat it. They don't know if treatment makes a difference yet. We have to tell the parents, oh yeah, you got this, and we don't know what it means. We don't know how to treat it. And then clearly in your last series of slides, you don't like the idea of aggressive TPN protein therapy. I agree with you on that. But I think what you've done here with all your mass spec of the amino acids, you uncovered a whole lot of noise. All these different levels, they vary from day to day. What does it all mean? It's just simply overwhelming. But I don't mean it as a negative way, but I just mean it's just simply overwhelming, and how can we afford to do all this stuff?
I get, Frank, I agree with that completely. I think that, as I tried to imply, we're in very early stages of trying to understand what this does mean. But I don't think that the noise is quite as bad as you suggest. And I think that there are, certainly because of the long-term experience that has occurred with neonatal screening, people like Don Chase, who we work with, have enormous expertise at looking at these mass spectrums and making sense out of them. They're not pure noise. I think the problem is, for example, if you go to just pure neonatal screening, the problem is that a lot of the states do not have the technique down that they should. There are really significant issues. When pediatrics was involved in neonatal screening, one of the issues that came up for us on a very frequent basis was, should we do the neonatal screening with our expertise in hundreds of thousands of babies a year, or did the state laboratory want to do it? Most of the time, because of political considerations, the state laboratories wanted to keep that responsibility. They had nobody really working with them in many cases on a specific basis, analyzing the data, checking the quality control of a lot of what they were doing, setting normative data for the values that were being obtained. And I know from before the time that I joined pediatrics, working in New York State as a division chief, I used to get all of these abnormal results back on my premature babies that I had a full head of hair before I started doing that. Right. And it was very frustrating because I think the state lab in New York had some significant limitations. I think they've gotten better from what I understand recently, but it was a serious issue. But they don't have the quality control or the scientific approach that I think is really necessary in this particular area. But I think that the evolution of what's occurring now, not only in perinatal medicine, neonatal medicine, but in cancer detection, in Alzheimer's disease, people are beginning to take that million protein mass of gunk and say, okay, we can eliminate, 990,000 of these proteins immediately. We're not interested in that in this case. And focus in very refined areas where the noise factor becomes less of an issue and the scientific approach becomes more important. I'm really quite convinced that something along these lines is really the future of medicine. It's a very compelling story. And I think the only thing in the way right now is our lack of understanding and perhaps to some extent the inadequacy of some of our tools to pull all of this out and sort it out in a way that makes sense. But it is happening. I can tell you that, for example, in the prenatal detection of septicemia and intraamniotic infection that our perinatologists are involved in, they're very excited about these early results. I think that this will have a significant impact on the way the pregnant woman is approached with very simple frequent screening for the ultimate detection of intraamniotic infection and earlier treatment and more appropriate treatment than we currently have. So I don't hesitate to agree with you at all that we're in our infancy here and there's a huge amount of noise, but I think that's the way that medicine starts in general in many areas, and I accept your concerns and for the most part at the present time agree with it, but I think these first steps are important ones.
I don't doubt that it's happening. I just think it's going to go a whole lot worse before it gets better.
You're probably right in that regard. Yes, I think you're next at the back microphone.
Oh, thanks. Let's say that your average community hospital has a Tandem mass spec and can easily run plasma amino acids. And let's say that you're concerned that your TPN solution might be resulting in hyperphenylalanine or low alanine levels or isovaleric acid levels, and you would like to do something about it, but your state Supreme Court has recently said that you can't just screen blood samples for hundreds of metabolic constituents without specific consent from the parents to do that screening. So all the samples that you'd collected for the past 10 years need to be thrown out before you can screen this. Do we know enough now that we could actually ask our community hospital Tandem mass spec lab to run plasma amino acids while we're giving the babies TPN? And do we know what we could do about it if there were abnormally high or low levels? And can we do it legally?
You're asking a lot of very interesting questions that we've wrestled with a great deal that are, I think, being looked at by a number of people at the present time. Let's take the issue of retaining these blood spots. That's, I think, one of the most tricky issues because of the potential for longer-term genetic analysis. You send blood to the lab all the time. They could put any of those blood samples on a blood spot and use that in any way. I think the issue here is how are we going to approach the entire field of genetic diagnosis. There's no question that within, or even at the present time, full genetic analysis from something I read very recently can be done now for about $1,000 to $2,000. Many people may become increasingly interested in genetic analysis.
That concludes this section of Pediatrics Grand Rounds. For additional information on the current topic, please go to our website, www.pediatrics.org.